I'm going to simplify this. My goal is to make this as easy as possible. So let's start off with one thing here. This whole lesson right here, I call the CAP system. Cardiac output equals heart rate times stroke volume. Now, this is so important. This formula basically dictates how the body responds to everything, basically stress, disease, drugs, everything. So first off, cardiac output. It's basically the amount of blood that the heart will pump to the body in 1 minute. Typically on resting mode, it's 5 to 6 liters, right? Remember, the kidney receives about 20% of blood perfusion in this time frame. But our homeostasis, everything in our body, will try to maintain our cardiac output demand, right? Cardiac output can increase in moments of exercise, but the whole point is that these factors here, heart rate and stroke volume, will change in order to maintain the cardiac output. That's how important it is. Our body will have a system that will always try to balance out the cardiac output that we need, okay? So heart rate times stroke volume. First thing that we need to know is that heart rate is mediated by a lot of the autonomic system. So heart rate, basically, you should know that heart rate is typically 60 to 100, right? And in heart rate, what you have is basically two receptors that are battling here. They're battling to take control. Typically in our body, they maintain a regular 60 to 100. You have beta 1 versus M2. And this opens up the door to a whole other concept called the battle of the receptors, because different systems rely on the balance of the stimulation of two receptors. So, for example, if we look at the vascular system, two receptors that we're looking at here is alpha 1 versus beta 2. You see, they maintain a balance. If you end up stimulating alpha 1 more than beta 2, then you have vasoconstriction, right? This is simple. It starts off real simple, but then, of course, it gets more complex. Now, what do I mean? I could also have vasoconstriction if I inhibit beta 2. So understand this. Understand that one is inputting positive stimulus and the other one is giving an inhibitory stimulus. Okay? Stimulation does not mean, like, let's say, a proactive, an increase in that tissue's action. That does not mean that. When you can stimulate a receptor to inhibit. I know it sounds a little confusing, but as, let's say, medical students, doctors, you should already try to do this exercise in your brain, where if you think, if I inhibit an inhibitor, I am activating, right? We should have that ironed out in the brain. Why? You would hate to get a question wrong, knowing everything, but getting tricked because the question was asking you, let's say, the inhibition of M2, right? I mean, think about it. M2 is inhibitory to the heart. So what is the effect of beta 1 versus M2? If you look at it like this, beta 1 has an increase in heart rate and contractility. Remember, it utilizes the secondary system that we mentioned before, GS. Last class, we went into the second messenger system of GS and how that works. And look at M2. M2 is GI. It's inhibitory. So you're seeing here that they are contradicting each other, the battle of the receptors. That's the whole concept. So if I stimulate beta 1, it's going to cause a tachycardia, increase chronotropicity, increase inotropicity. So let's get these words in TAC as well, right? We want to understand what all this means. For example, if I'm telling you I'm giving a drug that's increasing inotropicity, I'm increasing the strength of the contraction. The heart rate increases. So beta 1 is overactive or M2 is inhibited. Either way, heart rate increases. I'm talking to you about the chronotropicity, right? And they're not exclusive to each other. You could have an increased inotropicity and an increase in chrono. Now look at dromotropicity. This is exclusively speaking towards the conduction of the electrical flow through the myocardial tissue. Now, usually this is SA to AV node, right? This is this connection here, that PR segment. You can speed this up. There's many ways you can speed up the dromotropicity. Now, dromotropicity, if your nodes are functioning properly, it should increase the chronotropicity, right? I could give you an example, increase in temperature, let's say, that will increase your dromotropicity. So let's iron out the terminology, make sure that you know these terminologies. Different drugs can manipulate these things different ways, right? That makes sense. Okay, good. So yeah, we're starting off super simple. I'm just saying that beta 1 versus M2. This is what typically happens when you are looking at the determination of heart rate. Now, I'm going to also tell you stroke volume. And now we're going to make scenarios and show you how it all works. But one thing I want you to know, and you really need to know this pretty well, is the stroke volume is consistent of three things. So in stroke volume, you have contractility, afterload, and preload. I want you to remember this in this order. CAP. This is a very important mnemonic here, because you'll notice that the order of this is basically the physiological order of how we try to compensate when the cardiac output is not functioning properly. Contractility, like we mentioned before, it's basically the inotropicity, how hard the myocardial tissue will contract. What determines contractility? Well, we did mention it has to do with the autonomic system, beta 1 versus M2, right? Pretty sure I wrote that in here, right? Contractility increased and decreased. I mean, that makes sense, right? Okay. So to simplify this, let's get to the essence of this. I'm going to tell you that this has to do with the intracellular level of calcium. Intracellular level of calcium. Now you're probably asking why. Well, when we went over specifically the second messenger system, we mentioned the GS process. Remember the serpentine receptor 7 bypass? We said it's connected to the GS. At the end of all that, the adenylate cyclase activity, ATP, increasing the cyclic AMP, activating protein kinase A. At the end of all that, what do you get? You basically get an intracellular level of calcium. And you'll have, of course, still telling you here, myosin light chain kinase, smooth muscle contraction. So let's make sense of this, because first aid is an amazing tool to learn for this exam. Definitely recommend that everybody's on that first aid. That's like essential material that you can find. But I will tell you one thing about the first aid. Notice how it says here protein kinase A, and they'll show you an inhibitory signal here. And then it says myosin light chain kinase, smooth muscle contraction. Doesn't really make much sense. It's like, why is it inhibiting something yet you're having contraction? Well, let me explain. On my video of biochem, I basically go through the enzymes. One thing that I do mention is that kinase is an enzyme responsible for the phosphorylation of substrates, right? Can phosphorylate different types of substrates with kinase. Kinase utilizes ATP for this phosphorylation. Then, of course, there's something called phosphatase. Phosphatase has a T, it takes away. It takes away a phosphate. It takes away a phosphate. So I'm just going to explain it to you like this. Why, just to understand exactly why it has an inhibitory signal, yet we're talking about stronger contraction. All right, so this is what the first aid is not telling you. In the sense here, when you activate protein kinase A, you start to activate phosphatase inhibitors inside that myocardial cell. Basically, phosphatase, I told you, takes away phosphate, and I'm activating an inhibitor. That's basically inhibiting an inhibitor, and that will give you stimulus because you basically inhibit the activity of protein phosphatase. So phosphatase takes away a phosphate. So now I'm not taking away the phosphate anymore. So then myosin light chain kinase is now able to thrive, and it's able to provoke, and this is through calcium calmodulin, it's able to provoke a stronger contraction. All I'm saying is this: protein kinase A inhibits phosphatase. So you're inhibiting an inhibitor, and then you're getting basically activation. Activation of myosin light chain kinase. Right? And this will be available in the notes as well. I'll post the notes right after the class. So we're making sense here. Point of me bringing this up is just to let you guys know that when you activate beta 1, you have an increase in intracellular calcium. You'll have an increase in inotropicity, increase in chronotropicity, okay? Just like we mentioned here. Hopefully that makes sense to you. This is due to the intracellular calcium. GI system is basically the opposite. You basically turn off the adenylate cyclase. That way you don't have the increase in cyclic AMP, you don't have protein kinase A, you don't have that increase in intracellular calcium. That makes sense. Good, good. Okay, everybody understands? We're going to continue. Right? All right. So basically, we spoke about, so we're talking about the three different factors here: contractility, afterload, and preload. We just said that a lot of contractility is determined between beta 1 versus M2. Okay, let's look at afterload. What is afterload? How does afterload work? This is something that we need to know. We need to simplify this. Imagine here, you guys are seeing right here, this is the aortic valve. Aortic valve. The aortic valve has to set a threshold. So there has to be a certain amount of pressure. Basically, you must overcome a certain amount of pressure in order to open up this aortic valve. The rule of pressure is that it goes from high pressure to low. That's how pressure flows. So this ventricle here must be able to make more than the aortic valve threshold. So the aortic valve rule here is that it'll only open if you can produce more than 120 on the left ventricle when it comes to pressure. So if you're producing more pressure in the left ventricle, then you'll be able to open up this valve. That's afterload. Afterload is just the idea of that threshold. We can play around with this threshold. We can increase it. That way, the left ventricle must achieve higher pressure in order to have a proper systole, right? And remember, when the ventricles are achieving proper systole, they're doing this on this one phase, this isovolumetric contraction. This is a part of the cardiac phase. We won't get into that today, but I'm just going to mention this isovolumetric contraction is such an important phase here. Why? Because here the ventricles was able to close the mitral valve completely, make sure that there's no influence from the mitral. The aorta is already closed, and you're able to contract this myocardial tissue as much as you can on the left ventricle. That's when it produces the pressure needed to overcome that threshold that was set by the aortic valve. Good. So how do we manipulate this? How is this important in physiology? Well, I'll tell you. The valve itself, aortic valve, has to deal right behind the aortic valve. You have the aorta. And if I'm able to contract the aorta, if I'm able to have the aorta very contract, the lumen is very, let's say, reduced, small lumen, because I'm contracting it, then I'm automatically increasing the threshold, because basically once the aortic valve opens, it has to combat against this narrow lumen. So this is the nice thing right here. I can manipulate the afterload by playing around with alpha 1. Why? Why alpha 1? Well, because like we mentioned before, alpha 1 is the main receptor here that's going to contribute to vasoconstriction, right? And alpha 1 is the GQ system, the second messenger GQ system. All I'm saying is that alpha 1 will reduce the lumen. So this aortic valve, now let's say this is the aortic valve here, it basically increases the afterload. It's like a door, and you have to walk through this narrow walkway. It gets more narrow. Now, basically, you have to increase the threshold, right? So a lot of afterload itself is going to go hand in hand with alpha 1 stimulus, okay? So understand that. Alpha 1, so let's go back to the drawing, and I'll show you. Alpha 1, so we said contractility, a lot of it has to do with beta 1 versus M2. And we said the main thing was calcium because of the intracellular secondary messenger system. Now, afterload, we're saying that it has to do with alpha 1, right? And at a physiological level, we want to stimulate alpha 1. We have something called norepinephrine, which has more affinity towards alpha 1, right? We also have epinephrine, but epinephrine has more affinity to alpha 1 on higher dosages. That E kind of looks like a B. So that helps me to remember that epinephrine, instead of just like alpha 1, it actually favors beta, right? It's one of those beta types of reactions. So E looks like a B, it favors beta. Okay. So far, so good. So yes, correct. That's one thing you guys really need to know, is that whole idea of second messenger systems, alpha, betas, and all this, because this is where it comes into play. Now, why do I say that this is so important? Because of pharmacology. In pharmacology, you can play around with these receptors. You can activate one, inhibit one. And there's questions that basically become free questions, free points. The questions that have that whole drug X. So, patient was given one drug and this is his heart rate. And then he was given drug X. And now his heart rate either increased or decreased. If you understand these kind of hemodynamics, if you understand the autonomic system, those questions become a lot easier, right? Good. So far, so good, right? Everybody understands. All I've mentioned was contractility, how we manipulate it, afterload, how it can be manipulated by alpha 1. Now we're going into preload, right? So first off, what is preload? I would have to tell you preload, you'll see that has to do with the stretching of the ventricle. So in preload, it all has to do with the stretching of the ventricle. I'm going to show you an image here. So what determines the stretching of the ventricles? Of course, the volume. So preload is basically the volume that goes into the left ventricle, because if I have an increase in volume, I have an increase in preload, because there'll be more stretching, of course, to accommodate that volume entering the left ventricles. That makes sense, right? Something very important to understand when it comes to preload is that you have to know the Frank-Starling mechanism. Now, so what am I talking about, Frank-Starling? This is the idea that if you stretch, let's say, some type of fibers, you stretch them to the maximum capacity. The moment you let go, the excessive extension that was actually achieved will contribute to an increase in the pumping force. Basically, it would transfer to increase in force. So what do I mean by that? Let's say I have a balloon. This is a good example. Say I have a balloon and I blow up the balloon as much as I can. Notice that if the balloon is very much extended, the pressure that comes out of that balloon when I let go is very, very strong. Now, if I blow that same balloon to 25% capacity and I just let go, I'll have minimal pressure. That's the idea of Frank-Starling mechanism. Don't try to memorize definitions. Understand them. Understand that increased preload in this sense can influence the contractility by expansion of the ventricles, extending them to maximal capacity. So if you have something with fibers that are extended, when you let go, it will snap like a rubber band, right? You take a rubber band, you extend it to the maximum capacity. When you let go, it snaps. Versus you taking a rubber band and only extending it to a minimal level. Notice that the recoil will not be as strong, right? That's Frank-Starling mechanism. So preload basically has to do with volume. And what's volume? Basically venous return. That's how you're getting blood into your ventricles. So venous return, volume, preload. Look at these words. Notice how these words are going hand in hand, right? Increase venous return, that's an increase in volume, that's an increase in preload. So understand that. Well, this should make sense. Like we said, cardiac output equals heart rate times stroke volume. And we said cap. So let's say contractility decreases. There must be a compensatory mechanism. Either heart rate increases or something here on will change. And this is what we're going to talk about today. That response that we get, that change, the physiological change, the compensation that we achieve. Right? At a physiological level, that can happen. And the reason I told you to memorize this, remember CAP system, CAP, is because you're going to see charts. And we'll get into charts, not on this class, but we'll do this on the next one if everybody understands this lecture properly. CAP system, if you've ever seen this chart, this graph before, take a look at this. Contractility is measured on this plane. So increased contractility should be increased here. Remember what I said, contractility, a lot of things can manipulate it. We just mentioned preload manipulating it as well. Afterload. Afterload is measured here on this plane. So if I give something that, like phenylephrine, constriction of alpha 1, look at the afterload, it will increase. That has to make sense. And then we have preload. Preload increases at this level. This is something that's measuring the preload and systolic and diastolic volume. And yes, you can find yourself in the cardiac cycle with this little chart right here. And we'll explain a lot more. We'll be able to manipulate charts now. And we'll be able to talk it through. You don't have to memorize any of these charts or anything. We'll just be able to say, okay, well, this physiological state will do what to the stroke volume? Oh, it'll increase afterload. Okay, so then in the chart, it should be represented as such. It should have an increase here. So volume is here in the bottom, and pressure is here on the y-axis. So I always like to find myself in the cardiac cycle in my favorite one, which is the isovolumetric contraction. Why? Because that's the part where the volume is at the maximum, and that's the part where the pressure increases. Isovolumetric contraction. So I find myself right here in isovolumetric contraction, always. This here's the ejection phase, where you're losing your volume because it's going to the circulatory system. So we'll definitely talk more about charts, and we'll have a general understanding of everything. But this is important to learn this in this way with a CAP system, CAP. All right. We'll also remember that the isovolumetric contraction is the same phase where you're consuming an excessive amount of oxygen in order to achieve this powerful contraction. So if there's ever any type of ischemia that occurs at the cardiac level, it'll occur on this phase, right? That makes sense. That makes sense. So yeah, ST elevations, we'll talk about all that and we'll make sense of it all. You can see this on EKG. EKG, that's the QRS, ventricular contraction. So we'll include EKGs on this and make this all make sense. So let's continue. Okay, so what I'm talking to you about now, let's see this at work, because it's nice to know all this. Having all this information is very useful, but if you can't put it in physiological circumstances, situations, then it's pointless. So let's understand this properly. Let's say, for example, you have a resident and an intern, and the attendee says, hey, put an IV on this patient here. And let's say the resident tells the intern, hey, put an IV. So the intern didn't do it, so the resident did it. So then the intern says, hey, I totally forgot to give IV fluid. Let me go give some IV fluid now. So he also puts an IV on the patient. So the patient has an excess of volume. So let's look at this right here. Let's follow the code here. Hopefully you're understanding what's happening here. They put 2 IVs on this poor guy, this poor patient, iatrogenic issues now. So what we have here is that, remember, CAP. You have a patient now who has an increase in preload. Why? Because we're increasing the volume. That's an issue. That's a huge issue. So we must now compensate. We must now change these dynamics of the cardiac output in order to maintain your normal cardiac output. Okay, so let's understand this. This is like a situation of volume overload, basically. So what we have here, let's say, we have an excess of volume. This excess of volume, when the ventricles contract, makes its way here to these baroreceptors. This is the carotid sinus. So let's become familiar with the carotid sinus. This yellow ball right here, basically. Imagine this. With this yellow ball, whenever I make contact with it, it activates. Let's be clear. Whenever I make contact with this yellow ball right here, carotid sinus, basically, it's going to activate. It's going to send a signal, depolarization signal, to the afferent nerves. Afferent. So the afferent nerve system here will basically make its way to the medulla, right? The medulla at the neurological level. So let me show you an image of medulla. Got to make sense here. So we basically have an increase in volume. This increase in volume was able to press on this carotid sinus. So this carotid sinus ends up sending a stimulatory signal to the afferent nerve. The afferent nerve is also known as cranial nerve 9. So what happens here when you have stimulus of cranial nerve 9? You're going to basically, it's going to have a nucleus here. So cranial nerve 9 and 10 are like brothers. They are basically always relaying information to each other. So on this system, you'll see that there's something called a nucleus tractus solitarius. And this nucleus here is able to receive the signal from cranial nerve 9, telling it, hey, we're activating now, because the carotid area is being pressed upon. So we're going to activate ourselves. Glossopharyngeal nerve says, okay, well, I gave my signal to cranial nerve 10. Cranial nerve 10 complies. He says, okay, well, you want to activate? Let's activate. So cranial nerve 10 now is activated. So let's remember one thing. Cranial nerve 10 gives parasympathetic input to the heart. And like we mentioned before, we have beta 1 versus M2. So if you stimulate the vagus nerve at a parasympathetic level here, of course, it uses the neurotransmitter acetylcholine. So you're sending acetylcholine to M2. So you're going to basically decrease the heart rate and decrease the contractility. And that's what we need at the moment. Why do we need this? Well, because we have too much volume. So now cardiac output will regulate itself, right? We call this reflex bradycardia. Cardiac output, like we said before, and this is the same theme, it won't change. CAP, it had an increase in preload. So the body understood this problem because of the baroreceptors and was able to relay an afferent signal via glossopharyngeal nerve towards the nucleus tractus solitarius, which relayed that signal to cranial nerve 10. And then cranial nerve 10 said, okay, well, you want activation? Let's activate. So it sent acetylcholine to the M2 receptors, leading to a decrease in heart rate and decrease in contractility. Hopefully that makes sense to everyone, right? Okay, so that's a reflex bradycardia. Utilizing these same dynamics, they were able to regulate cardiac output. It's the same idea with drugs. And once we get the idea of everything, we'll add drugs, we'll add physiological situations, we'll make sense of it all, okay? Perfect. So everybody's with me? No questions yet? Everybody understands? Let me know in the chat. Just say yes, okay? Say yes if you understand, because we're going on to now the next scenario. That was one scenario, which is volume overload. Next scenario, imagine this. All right, so we're in the hospital, and let's say a patient gets rushed to the emergency center. Patient is losing an excessive amount of blood loss through wounds, and it's a real serious issue. So, okay, what's going to happen in this situation? Well, let's see. At this situation, let's say here's the heart. It's trying to comply with the whole rule of cardiac output. Here, if we look at the equation, what do we have happening here is that CAP, let's say. Here we lost volume. So it's a decrease in overall stroke volume. Okay, well now the heart rate must respond. So what happens here? Going back to the same concept that we just mentioned. If this patient, for example, lost volume, he wouldn't be able to press on this carotid sinus like before. Before he was able to press on it, the vessels came along like this. Now you have less volume. So now imagine that these vessels are not touching it, right? And when you don't touch it, it sends an inhibitory signal. So again, same story, afferent, which pertains to cranial nerve 9, will relay a depolarization signal to the nucleus tractus solitarius, which relays that same inhibitory signal to cranial nerve 10. Now, cranial nerve 10, if I inhibit an inhibitor, let's remember, guys, it's the same theme. I'm inhibiting an inhibitor. What am I doing? I'm allowing beta 1 to thrive here. Beta 1 will thrive. It makes sense. So let's take a look at that. Look at this. If I inhibit M2, beta 1 wins the battle. So what happens to this patient now? His heart rate basically increases. Reflex tachycardia. Okay? Remember that. Remember that. Now, I gave you an extreme example. I basically gave you an example of a patient who's got stabbed and lost a bunch of blood. That doesn't have to be the case. Let's remember, if we stand up really fast, a lot of our circulatory system basically redistributes the blood to the inferior members, our legs, basically. We'll have our blood being redistributed to our legs. We'll have a decrease in volume. Our heart will perceive that, and it activates this system. Now, this system will increase both the heart rate and the contractility in order for us to not undergo syncope. And this is why you could feel maybe a little dizzy if you stand up too fast, but notice you don't end up passing out because your system here is functional. It's working. Okay. Let's say there's an older patient. When the elderly basically end up having issues with their nodes and their autonomic systems. So it's not that they completely lose it, but it's not as sensitive as a younger patient. So you'll see a lot of older patients who can experience syncope basically because of this issue. This issue is not as reactive as it should be, right? Also, if I manually stimulate the carotid sinus, if I start pressing on it manually, well, what am I doing? Manually, I'm making contact with the sinus, pressing it with my fingers. I'm pushing it with my fingers, basically, letting it know, hey, activate yourself. So what would it do? Cranial nerve 9 sends the signal, the afferent signal of activation, of stimulation. Remember, when you touch, you activate. And this relays the signal to cranial nerve 10. When I activate cranial nerve 10, I decrease. Remember, activation of cranial nerve 10 decreases chronotropicity, inotropicity. So that's how carotid massage basically can decrease your heart rate. Okay. But here we're talking about an increase. A patient who stood up really too fast. There was redistribution of blood to his inferior members, his legs, basically. And then what ends up happening? This system gets activated. And this system is amazing. It's a system that's supposed to work. It's only supposed to basically take control of your cardiac output for seconds. For seconds to make sure that you don't pass out. This is not a system that you can have for long term. This does not regulate your cardiac output for long term. This is just something that is basically held so everybody doesn't have syncope and falls over. Okay? So that's the first one. That's CAP. Contractility. In order, we're going in order. We're saying that C is this system of the carotid sinus. That's contractility. Contractility, carotid sinus. Right? B1 versus M2. Perfect. The same theme over and over again. This is going to be super easy toward the end of it. The next system. So let's understand what happens. Our body, let's say you continue on with this system, this relay system of the baroreceptors, bringing the cardiac, the chronotropicity up higher. But let's say it's not achieving what you set out to achieve. It's not regulating the cardiac output. Well, our heart starts to pound really fast. Our brain starts to perceive this as life-threatening, right? The amygdala is able to perceive any type of danger that threatens our life. And this amygdala relays this information towards the limbic system in the brain. So I'm talking to you now about the second one. We went through contractility, now we're on the second. The second reaction has to first be stimulated by our brain. We start to perceive life-threatening danger. Our heart is increasing, its rate, pumping super fast. And our brain is like, hey, I might die here. I have to survive. You activate the fight or flight response. Amygdala, limbic system, the hypothalamus has sympathetic chains, right? And that's more of neural. Neural is my favorite subject out of all subjects. And we can get into that whenever we do neural, but I will explain to you one thing. The danger that is perceived by our brain allows stimulus of the sympathetic system. So let me be clear, and I want to be super clear on this. Look, acetylcholine is the main neurotransmitter. I don't care what anybody says. I'm just telling you right now, acetylcholine is the king of it all. Why? Because via acetylcholine, you activate the sympathetic system, right? Let's keep that in our mind. The sympathetic system, let's say the activation of norepinephrine and epinephrine is via acetylcholine. But acetylcholine itself activates the parasympathetic. So let's make sense of that. Acetylcholine must activate the sympathetic, and then the sympathetic will release norepinephrine and epinephrine. We can make sense of this all. I'm going to show you this image. Let's see. This has to do with the autonomic system here. And also, I should also tell you this information, this signal that runs down the body, it's going to be sent towards the spinal cord. And the spinal cord has this sympathetic, it's called the lateral horn. Remember, guys, we know the anterior horn, right? That's so high yield. We know the anterior horn that has to do with movement, right? The lower motor neurons. That's the anterior. We know basically there's also the posterior horn that has to do with receiving a lot of stimulus from tracks, just letting you know. But okay, anterior horn. The lateral horn, almost nobody talks about the lateral horn. But the lateral horn is involved in the sympathetic stimulation that we will talk to you about right now. The sympathetic stimulation, basically, which goes through here, actually, via this pathway. Here, let's look at it like this. Notice, this starts running down, and it utilizes acetylcholine. Acetylcholine will stimulate the adrenal gland. All right? And one thing I should tell you is that the adrenal gland itself has something called chromaffin cells. And chromaffin cells, remember, that's derived from the neural crest cells, is what will allow you to release norepinephrine and epinephrine. Okay? Now, remember, these are catecholamines. These are catecholamines. This is what we call an adrenaline rush. The brain itself does not have the proper enzymes to release epinephrine. So the brain itself is releasing norepinephrine. But here, these chromaffin cells, they do have what it takes to release epinephrine. The body just works perfectly that way. And just a side note, let me also include this information. If you look at this, right, the gray matter versus the white matter, let's understand what is that. The gray matter, look at the gray matter like the destination of the tracks. Tracks like to go to the gray matter. The white matter basically is where the tracks live. So it's like a highway and a parking lot. Passengers get off in the parking lot. That's gray matter. Remember that. Gray matter is receiving the stimulus, while the white area is where all the tracks are traveling, and that's how you distinguish between the two. So here, basically, you have this fight or flight response, which will stimulate that lateral area. And that lateral area, basically, you have this equipped, this lateral horn is basically between T1 to L3. Some books say L2, but T1 to L3. That contains the sympathetic neurons that will control the autonomic function. So yes, going back to what we're talking about, all I'm saying is that, back to our story, what's happening here, let's look at the big picture. What's happening now is that the patient, let's say, lost a lot of blood. What ends up happening is that he activated the first system we spoke about. Remember, the cranial nerve 10 was inhibited, so his heart rate went up. But guess what? That was not enough. So he perceived danger. He perceived life-threatening danger. So then what ends up happening is that he activated his sympathetic system via acetylcholine, stimulating the supraadrenal gland, the chromaffin cells to be exact. Chromaffin cells are derivatives of neural crest cells, just letting you know. But he activates the chromaffin cells, which will release norepinephrine and epinephrine at a high amount, also releasing cortisol because we're undergoing stress, right? So let's see what happens here. So this is going back to the physiology that we spoke about, and you'll see it make a lot of sense. Now we're talking about an increase in norepinephrine and epinephrine, and that will saturate, that would basically bind alpha-1. Remember, epinephrine at high levels will stimulate alpha as well. So now norepinephrine is released, and it's achieving vasoconstriction. It's achieving vasoconstriction, okay? Now, not only that, but cortisol has a permissiveness effect. It's able to potentiate the function of norepinephrine, right? It's making the contraction on these vessels very strong. So cortisol also helps out in this, but it's not indirectly. Norepinephrine is the main one I want to look at here, norepinephrine. That makes sense. Good. All right. Now, let's say, for example, we continuously do this. We have this on, this system is on, let's say for about 20 minutes, our adrenaline is through the roof, super high. Now, that CAP system, we said the contractility, it's something very short lasting, can't last too long. We said afterload, now we're talking about afterload. This is something that can't go on for too long. You can't have an adrenaline rush for an hour, 2 hours, let's say. That's excessive. So you get an adrenaline rush. You also start to utilize a lot of the nutrition that you have in your body. It also has to do with glycogen breaking down. That's a whole nother thing. That's in biochem, basically. But epinephrine plays a big role in that, right? The distribution of energy source. So that's limited. But we start to utilize a lot of this. What ends up happening, let's say 20 minutes later, after the adrenaline rush is now, after it peaked and I was going down, you end up basically as having such a potent vasoconstriction because norepinephrine will decrease the amount of perfusion that you get on the kidneys. Okay? So at the level of the kidneys, we said that 20% of the circulatory system, when it comes to oxygenated blood, should go to the kidneys. But here, this very potent vasoconstriction is going to decrease the amount of perfusion you have on the kidneys. And that will activate the juxtaglomerular glomerular cells, right? You'll have the activation of renin, right? And I'm not going to go like step by step with the RAS system. RAS system is more something that I do in nephrology, but I mean, we can do that as well. But for now, let's stick to the topic. What I'm talking to you about now is a sympathetic reaction that's definitely directly stimulating here the release of renin. And remember that renin will stimulate angiotensin 1, then you'll have conversion. In the lungs, you have basically angiotensin 2, right? And angiotensin 2, this angiotensin can actually constrict the vessels itself, so it makes this even worse. So the perfusion is now decreased even more. But what would end up happening is that eventually you'll start to stimulate something called aldosterone. Aldosterone stimulation is achieved at this level, right? So now we've mentioned the C, the contractility, we mentioned the afterload, now we're on the preload part. So this is how we actually increase the volume. So let's look into it. We have to know the mechanism of action of aldosterone. This is no exception to it. So let's go to the collecting ducts, the collecting part of the tubules, okay? It's going to be separated, right? We're going to do this first. Basolateral, let's say the word basolateral, I used to get confused with this with apical and basolateral, but just think about it like this. Basolateral has a B, so I think blood. Basolateral, I think, okay, this is the side where the blood is located. The apical side, here's the urine, basically. So learn how to learn, I would say. Well, what do I mean by that? If you know one thing, then if it's a dichotomous, if it's just like yes or no, if you know one thing, then the other one obviously will be the other. So I know basolateral, that's the blood side. And then, okay, so let's give this a little red color, just so we don't get confused. And then let's give this a yellow color. Hopefully that patient's urine is not this yellow, but okay. All right, so first thing we need to understand is that there's these two cells that will get stimulated with aldosterone. And let's understand this. You have first the principal cell. Principal, I'm just going to say principal, okay. And then we have the alpha intercalating. Yeah, my spelling is so alpha intercalating. Okay. Principal cell, there's 3 channels that will be upregulated by aldosterone. Aldosterone is able to enter the cell and stimulate mRNA synthesis. Remember, we call that transcription. If you guys were in my older class, we kept talking about the idea of mRNA promoting proteins, basically, through, remember, we had translation and transcription. So aldosterone stimulates the synthesis of mRNA for several types of channels. So you'll upregulate channels. What channels am I talking to you about? One channel is the sodium, potassium, ATPase, the good old sodium, potassium, ATPase that we know so well, right? This is everywhere in physiology. We understand this one. 3 sodium ions basically going out, and then you have 2 potassium going in. Okay. Then, of course, we have something called ENaC, and I'll show you this. Now, ENaC has an A on it, so I already know automatically that it has to do with sodium. So this one has to do with reabsorption, absorption of sodium. And then we have a channel called ROMK. Now, K is potassium. This one has to do with the efflux, let's say, of potassium. So let's put these channels on these cells. So we said in this side, we have the sodium, potassium, ATPase, right? Reabsorbing sodium, we said 3, and then this 2. That makes sense. Okay, then here on the apical level, the one that's facing that urine, we had ENaC, and ENaC is reabsorbing the sodium. And then we said we had ROMK. ROMK, I put the K really big because it's evident that here we're effluxing potassium. Hopefully everyone's on the same page. This is the upregulation that's actually done by aldosterone. Good, good, good. Keep that in mind. Now, that's one function on one cell. We understand that. That makes sense. But we must also understand its function on the alpha intercalating cell. Now, alpha intercalating has an A on it. A for alpha. For me, that A, what it really means is acid. Acid. So I think to myself, oh, alpha intercalating. Okay, well, that's just a cell that has to deal with acid. So we have to understand now, there is going to be carbon dioxide and H2O come together to make carbonic acid. You do have something called carbonic anhydrase, which when it upregulates, it's able to accelerate, catalyze the activity of carbonic anhydrase, converting these two elements into proton. Basically, you have here hydrogen and bicarb. So what aldosterone is doing here in the alpha intercalating cell, remember alpha for acid, is actually upregulating the enzyme carbonic anhydrase. Remember, carbonic anhydrase, you can find it on the PCT, but hey, you can also find it here in the alpha intercalating cell. So what will this actually do? Okay, well, you have these channels here. They're trying to save you, they're trying to help you out. And this channel here is going to release the hydrogen onto the urine. So efflux, basically, onto the urine. And this is an ATPase channel. Then you also have a proton pump. Remember, proton pump basically throws out the hydrogen. And then you have, of course, here, this potassium. So let's take a look at that. You're having basically the excretion of hydrogen, and that's because of the carbonic anhydrase due to the aldosterone. Now, something else. Nothing here is for free. You have to actually reabsorb this bicarb, but you have to pay up with chloride. You have to pay up with chloride. So don't worry, this will be on the notes. It'll be a lot clearer because my handwriting is not the best. But understand this concept. This is basically how you can now reabsorb volume. You're reabsorbing basically sodium. And sodium, we mentioned this before, and I will always keep on mentioning this. We mentioned that there's three basic structure. There's three things in your body, let's say. There's three molecules, which are always going to have a high level of osmolality. They're able to pull water wherever they go. They're so strong, these three molecules. They're so strong that in order to calculate the osmolarity in the body, we actually do an equation with these three things: sodium, glucose, and urea. These three things have high osmotic value. They pull a lot of H2O wherever they go. All right? So if that makes sense, then here we have sodium, and sodium is pulling a whole bunch of H2O. Right? And also, I should mention here on this principal cell, you can also have ADH. If ADH gets activated, if ADH is activated, you'll see that ADH will open up aquaporin channels, again on the apical side. And these aquaporin channels will be able to pull in water. Okay. But they pull in water, of course, they pull it in, but at what cost? With some urea. All right. Okay. 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 Good. This makes sense. Now, I should also mention, okay, so what do I mean by this? So now let's put this back into physiology. Going back to the whole idea of, I feel like we just did renal out of nowhere. But okay, cardiac output equals heart rate times stroke volume. What I'm telling you is that the first one of the CAP system was C, contractility. Remember, there wasn't sufficient amount of volume to stimulate the carotid sinus. And since there was not any stimulus of the carotid sinus, there was inhibition. So I'm going to say, basically, there was an inhibition of cranial nerve 9. Cranial nerve 9 sent inhibition to cranial nerve 10. That inhibition, basically, what that ended up doing was increasing heart rate. That increase in heart rate was not enough. The heart rate increased, the heart is pounding. Our patient thought, oh my God, I might end up dying. This is bad. So he ended up stimulating the sympathetic system. The sympathetic system is basically what we mentioned, with acetylcholine coming from the sympathetic, preganglionic sympathetic chain on the lateral horn. Remember we mentioned that? And this stimulated the supraadrenal gland, the chromaffin cells, which released norepinephrine and epinephrine. So this ended up increasing alpha 1. Alpha 1, remember we said, is afterload. Okay, that was not enough. That was not enough. We set up a whole strong threshold in order for the heart to have a really strong contraction. But guess what? That was not enough. So now this norepinephrine and epinephrine in circulation started to constrict the vessels so much that the kidney did not receive its 20% circulation that it should have, oxygenated blood. So then stimulated the RAS system, the renin-angiotensin system. And that RAS system ended up stimulating now preload, increasing the preload. And the preload is such a great tool because it does both things here. It's entering so much volume that the Frank-Starling mechanism will increase the contractility regardless, right? But there's an issue. Now let's explain the problem. This is the system. I hope everyone understands it. Now I'm going to explain one thing. The issue here is basically, how long can you keep this CAP system going? Well, the P in the CAP system, how long can we keep this going? The answer is, we can keep this going for years. 4 years, this patient has basically compensation of his heart failing. Basically, he ends up having, with time, when volume keeps on increasing, he'll have a congestive heart failure. When that Frank-Starling mechanism isn't working anymore, because the actual, let's say, the sacromeres, they're not compliant. They're just basically the heart is now having systolic issues where you cannot contract properly. So let me tell you, when there's hypertrophy that goes on, you have an eccentric ventricular hypertrophy. And here the sacromeres, remember, are in series. Sacromere are in series. And what ends up happening here is that the heart will not be able to compensate properly. It cannot achieve the cardiac output that it should. That's decompensated congestive heart failure. Why is it congested? Because you're increasing preload so much. That's one thing that can happen, right? Then these are patients who have issues. They're lying in bed. They can't sleep. They feel like they have dyspnea when they lie down in bed. These are patients who basically have this S3 problem, right? But let me also include another thing as well. Let's say instead of going that route where they have congestive heart failure, let's say they are so reliant on this preload, and this preload is so high that the heart itself starts to stretch. If there's an increase in stretch of the myocardial tissue, it will release AMP, BMP. Now, this system is created. This system is perfect. Why? This is like the breaker lights. Let's say I have too much electronics on at the same time. Then the electricity system in my house will, boom, it'll go out. Before I fry any of my appliances, it'll go out. So AMP-BMP is this system that if you have way too much volume, way too much of an exaggeration on your preload, and we can sense this exaggeration because of the stretching of the myocardial tissue. So if preload is exaggerated, then you'll stimulate the release of AMP and BMP. AMP, BMP, what is its function? Well, remember you have afferent and efferent. When we're talking about the kidneys, you have Bowman's capsule right here. But if I dilate the afferent, then I'm increasing how much blood, how much perfusion is going into the capsule. But if I constrict the efferent, make the efferent, let's say, very narrow, then the pressure here on Bowman's capsule will increase. And this pressure is not only going forward, remember, you're also having filtration. So the AMP, BMP will definitely lead to a release of this excessive volume. And when you remember, this excessive volume was necessary because it was compensating the patient's cardiac issue. So then when you release volume, then you activate that same cap system that we spoke about. And this becomes a vicious cycle. That's the problem here. That's the issue that we have here. This becomes a vicious cycle. Now, there's a whole bunch of questions. You'll see a whole bunch of things that have to do with this whole idea on New World. There's a lot of questions just based on everything that we spoke about today. And I see it everywhere. I see it everywhere. They don't call it the cap system. Let me be clear. We're calling it that right now. Cap system. They don't call it this. Instead, they'll call it sympathetic activity. Activity. That's what they'll call it. Okay? So keep an eye out for that. And look at, for example, this is straight from UWorld. I'm going to show you guys. I mentioned this before. Take a look at this. Decompensated heart failure. This is the issue. Volume overload. Myocardial stretch. You have a reduced in cardiac output. Why? Because Frank-Starling mechanism no longer is functioning like it should. Remember, that's the issue here with this congestive heart failure. So then you stimulate AMP and BMP. Then you'll have vasodilation, saltwater retention, decreased afterload preload. And then the whole pathway keeps going on, keeps happening, gets worse. So everybody basically who's doing UWorld questions, think about this lecture when you're doing this UWorld questions. Look at the dynamics of it all. It should all start to make sense. It should all start to make sense. And you'll see that one thing is trying to basically compensate for the other. That's how it's always working. Next class, we're going to talk about drugs. We're going to take the same concept. Hopefully everybody understood this, because now we're going to play around with it. We're going to put it in charts. We're going to add drugs to it. For example, look at this chart right here. Look at these drugs. Notice how I mentioned the renal blood flow decreasing with an increase in norepinephrine. And that's what will stimulate that RAS system, renin-angiotensin system. Notice everything that we're mentioning here is making sense. These are drugs. This is how they're playing around with everything that we spoke about. All right? I want you guys to understand this, not to memorize. Cardio is one of those subjects that you need to know your concepts well. It's not one of those like micro, like it's one of those things that you just have to know your concept, because they're going to ask you questions based on any part of the physiology, any part of the concept. Okay. Let's say, okay, so now I'm looking at the questions. Let's see. Stroke volume equals cap. Sympathetic activity. Do you mean that, doctor? Good question. So let me tell you, I do mean sympathetic activity, but this is the thing. I don't want to directly call it that. And I'll tell you why. Because in the cap system, take a look at this. Remember, when we said contractility, is it really sympathetic, or was it an inhibition of cranial nerve 10? Remember, you actually inhibited the input of this parasympathetic system by relaying the inhibition through the nucleus tractus solitarius via afferent cranial nerve 9. So yes, sympathetic system does thrive here because beta 1 wins the battle versus M2. Beta 1 will win. So that is a win for the sympathetic system, but that's not really like, let's say, something direct. Now, when we mentioned afterload, that is directly the sympathetic system. That is directly stimulating catecholamines, norepinephrine and epinephrine. That is 100% sympathetic. Yeah. And that's how they like to call it on UWorld. You'll see that they'll talk about this system. They'll mention it as a sympathetic activation. And then when it comes to preload, this is volume. Is this sympathetic really? Well, indirectly, remember, norepinephrine decreases the perfusion of the kidneys. So norepinephrine is sympathetic. But when we talk about aldosterone, what actually stimulates aldosterone is going to be angiotensin 2, which is a vasoconstrictor. So yes, it is a sympathetic system thriving, but in some portions it's direct and some portions it's more indirect. All right? So hopefully that makes sense. Any questions, let me know. Write down your questions and let's talk about it. Because this needs to be understood. This does need to be understood. All right? Anybody else? Hopefully everybody understood everything. Right? So ask away, guys. I'm here for any types of questions. So yeah, this can be manipulated with drugs. This can be manipulated many different ways, physiologically as well. Exercise can increase cardiac output. We'll see that as well. All right. So could you please post on YouTube? Yes, I will post on YouTube. Oh, can you repeat how norepinephrine changes the preload again? Sure. So the increase in preload, yeah, definitely. So let's look at this. So like we mentioned, norepinephrine was released from the supraadrenal gland. Remember that lateral horn in the spinal cord. The lateral horn in the spinal cord was able to send acetylcholine to the supraadrenal gland in order to stimulate the chromaffin cells and release norepinephrine. Okay, we understand that. Norepinephrine has high levels of affinity to alpha 1. Okay, high levels of affinity to alpha 1. Now, if alpha 1 is super constricted, let's say, so constricted that you're not allowing basically any kind of perfusion onto the kidneys, because you're prioritizing this vasoconstriction, basically trying your best to maintain the cardiac output, trying your best to have adequate afterload in order to maintain this cardiac output, that the perfusion from the kidney is now lacking. Remember, I told you that 20% of, let's say, blood circulation should go to the kidneys. If this is not the case, then you are going to activate the juxtaglomerular cells. This is in the macula densa, the kidneys, will activate renin. And then renin will run basically the RAS system. You have angiotensin 1 converting into angiotensin 2. Angiotensin 2 will stimulate in the level of the supraadrenal gland aldosterone release. Aldosterone, remember we mentioned that aldosterone has 3 main principal jobs that it does on the principal cell. And one of those jobs are the upregulation of ENaC. ENaC has to do with the reabsorption of sodium. Sodium makes its way back into the bloodstream, but not by itself. It brings with it H2O. And remember we said H2O volume equals preload. That makes sense, right? Any question, let me know. So this was a couple of things. Look, norepinephrine, decreasing perfusion. It decreases the perfusion at the level of the kidneys. So take a look at that. Norepinephrine, renal blood flow decreases. Decrease of renal blood flow activates RAS, which is the renin-angiotensin system. RAS stimulates aldosterone. Aldosterone increases the reabsorption of sodium via ENaC. And that reabsorption comes with H2O. So increase in volume. That's basically it. So yeah, anybody has any questions, I will explain. And next class, we can talk more about the actual. So this was more of a lecture kind of class. I like to run drills. I do lectures. I do questions as well. So I sit down now with this concept in this study sessions that we're going to do, these following sessions. I will also do questions. We'll put up questions and we'll see if this holds up, right? This has to make sense. There can't be any contradictions in this physiology. It has to be perfect. It has to make sense. So we'll sit down with some questions and we'll be able to use what we just learned to answer the question, because that's the most important part of this, right? You don't only just want to learn all these concepts. You have to have some kind of utility to this. You have to be able to get your answer correct. All right. So yes, that's about it. This was like an hour and like 10 minutes, 15 minutes, which is good. Definitely. I hope everyone understood everything. If anything, let me know on the chat. Definitely stay in contact. We'll see how we move forward. Definitely. Thank you, everybody, for joining me. Again, my name is Dr. Batista. You can find me on Instagram. Follow me on Instagram. Follow the WhatsApp group if you're not in there. Definitely, because I'll use that to post wherever I give class.